Dr. Wilma is a director of, an executive medical director for leukemia, lymphoma, and executive, and sorry, in stem cell transplantation. I have echo. In MD Anderson Cancer Center in Houston. His research focus is identifying immunology and immunotherapy strategies for hematological malignancy, particularly chronic lymphocytic leukemia. He's a worldwide figure in CLL, and today Dr. William will speak about are we reaching a cure in CLL? Please, Dr. William, go ahead.
Thank you very much. Can you hear me? Are you able to hear me?
Yes, we can hear you. We can see the slides as well.
Perfect. Okay. Thank you very much. Thank you to the Saudi Society for Blood Disorders for this opportunity to speak to you about chronic lymphocytic leukemia. And my topic, as mentioned, is are we sitting on a cure for CLL? There we go. This is a topic that is, I'm grateful to be given this topic and to sort of review the data in the perspective of working towards a curative strategy. This is sort of a new approach in terms of having a discussion. Usually we talk about what are standards of care and how are our treatments progressing, but this talk and organizing for this talk gave me an opportunity to step back and say, okay, where are we for cure? We talk more and more about cure. We have regimens that we think are working towards a cure. And so it's nice to put that concept in perspective with the treatments that we have. A couple of thoughts on cure and how we define cure I highlight in this slide. I think people think in the purest sense of the word, cure would be complete eradication of the leukemia clone, never to return, and patients having a normal lifespan for most of the patients who are receiving a particular treatment. Today, that may be the case with FCR and for patients with a mutated IGHV gene. We have long enough follow-up from those patients to say that there are a number of those patients, about 50% of them, who remain MRD negative with many years of follow-up, 10, 15 years of follow-up. Those patients may be cured by this definition, but I think there are also other concepts of cure that we're working towards and we should think about, particularly for CLL, because CLL, as you know, is a disease in the older population. That patients may get treatment, may remain in remission for long enough period that something else, they will die of something else, natural causes, and their CLL may not be what shortens their lifespan. So another concept to address here is remission with no future need for treatment and a normal lifespan. The clone in this case may be persistent, but doesn't require treatment. And then finally, patients, and I think we're here now, patients may have a normal lifespan despite needing treatment and despite maybe not getting rid of every clone, and patients going through a series of treatment. And as I mentioned, right now my perspective and my thought is that we're probably here for most of the patients, particularly those over 65 years of age, because we have now very effective targeted therapies, and we're working on combinations of targeted therapies. As you probably all know, the evolution of treatment has been, I think, remarkable for CLL. This slide just summarizes the evolution and agents that we've had available, moving from chemotherapy through combined chemotherapy to chemoimmunotherapy to targeted therapy, which is monotherapy, and now we're in an era of combined targeted therapy where we're combining our agents that work on different targets and achieving a very high proportion of patients who are undetectable in terms of MRD. We don't yet have the sufficient follow-up to say that those patients are cured, but I do think that that will come with further follow-up. We've had a number of agents that have become available for treatment for our patients, and this categorizes them according to how they to their mechanism of action. Most remarkable has been the recent inhibitors of the B-cell receptor signaling pathway, particularly BTK, and BCL2, particularly venetoclax. So a few concepts in terms of goals of care. As I mentioned, potentially curative therapy, as I defined it in the first slide, with FCR in patients who have a mutated immunoglobulin gene. Allogeneic stem cell transplant may offer cure for some patients. Most of these patients are older. Most of them have comorbidities. With chemotherapy, this used to be a bigger issue. It still is somewhat of an issue, but older patients don't tolerate treatments well, whether we're talking about chemotherapy, which is the clearest example. Also, with targeted therapy, we do see more toxicities associated with treatment. So in terms of our goals of care, we think of goals for patients in the frontline setting and goals in the relapsed setting. The first line setting is the best opportunity to achieve the deepest remission, and it's also the best opportunity to get the longest duration of response if we're talking about continuous therapy. So the two approaches right now with targeted therapy are continuous treatment, which is extremely good and effective, but patients need to remain on treatment. That's with the BTK inhibitor-based therapy. The alternative is fixed duration treatment, and that we have an opportunity to achieve with venetoclax-based therapy, where we're able to see very deep remissions with venetoclax plus obinutuzumab as a standard treatment. And then we consider retreatment at relapse, particularly retreatment with BCL2, and we can move to a BTK inhibitor subsequently for those patients if they become refractory to a BCL2 inhibitor. Goals of treatment for relapse disease really are to have long-term disease control and management of patients with the objective for them to live a normal lifespan and not die from their CLL. There are factors that I test for, particularly for patients who need treatment, that I need to know because we still have high-risk patients among those who get targeted therapy. It's important to check FISH and particularly to test for 17p deletion and for mutated TP53. Those patients, as you'll see, are in a higher risk category. And I also like to know what the IGHV mutation status is because I have different expectations for those patients, even with the newer targeted therapies, particularly with venetoclax-based therapy, where we're talking about a deep remission and time off treatment. So I test these three factors routinely when I'm thinking about a patient who needs first-line therapy. Now, there are a number of trials that have been published recently, and we have a long-term follow-up from BTK inhibitor-based treatment, shorter follow-up for CLL14. But if I start thinking about these in terms of curative strategies, I'm going to reverse sort of the order in terms of how I talk about them. BCL2 inhibitor, venetoclax, I'll start with because that's the best opportunity to achieve a deep remission and get patients off treatment. And some of those patients may be cured by the definitions that I spoke about earlier. These studies are all phase 3 studies summarized here. The first 5 are BTK inhibitor-based first-line therapies. All of them were positive, showing longer progression-free survival with BTK inhibitor-based therapy compared to chemoimmunotherapy. And then the last one on the list there is CLL14. That showed an improved progression-free survival with venetoclax obinutuzumab compared to chlorambucil obinutuzumab. These studies, all phase 3 studies, I think bring in the era of targeted therapy and make chemotherapy, chemoimmunotherapy, obsolete. Because we get toxicity with chemoimmunotherapy, we're able to achieve very, very good remissions, very durable disease control with targeted therapy, and it's much better tolerated than chemoimmunotherapy. My standard approach is summarized here in terms of frontline treatments. And I think about patients who have 17p deletion differently. Those patients, I think we need to right now put on a BTK inhibitor to control their disease long term. I'm in favor of a BTK inhibitor for those patients over a BCL2 inhibitor because while I think we can get these patients in remission, I worry about their disease if they're not on continuous treatment. Their disease, I cannot trust to turn my back on their disease, and I feel like I need to have them on some type of maintenance. So 17p deletion, mutated TP53, BTK inhibitor. For everybody else, I like fixed duration treatment, whether they have an unmutated or a mutated immunoglobulin gene. Most of those patients we can get in a deep remission. And we know if we get them MRD negative, they'll have a long progression-free survival. Some may never need treatment again. Some may need treatment, and we can go back to the BCL2 inhibitor fixed duration treatment to retreat if they have relapsed disease. And then we can move on to a BTK inhibitor if needed. So I'm going to walk through several trials that highlight and show you some of the important features in terms of the progression-free survival and overall survival with these targeted therapies. So the CLL14 trial I mentioned, I want to start with. There was an update from ASH this year for this study. It's a phase 3 randomized study of venetoclax obinutuzumab versus chlorambucil obinutuzumab showing improved progression-free survival with venetoclax-based therapy. The 4-year update is shown here, and you can see the 4-year progression-free survival rate of 74% is favorable over the 35% 4-year progression-free survival seen with chemoimmunotherapy. So very long, durable remissions. No difference yet in overall survival, but you can see an extremely good 4-year overall survival at 85% for venetoclax obinutuzumab. The venetoclax-based therapy is associated with a very deep remission, as I mentioned. That's highlighted here in the MRD data. On the left, you can see for venetoclax obinutuzumab, about 75% of the patients achieving undetectable MRD if you use 10 to the minus 4th as your sensitivity. This is in blood, and that compares very favorably to what's seen with chlorambucil-based treatment, which was 32%. And I should also point out that 40% of the patients who got venetoclax-based therapy were undetectable if you use a higher sensitivity of 10 to the minus 6th. And those are the patients who do extremely well in terms of progression-free survival and have improved long-term outcomes. So just going back here to reiterate the blue curve, which is the progression-free survival curve with venetoclax-based therapy. This is 1 year of venetoclax with 6 cycles of obinutuzumab. If you move forward to BTK inhibitor-based therapy, this is the progression-free survival curve we see with continuous treatment with ibrutinib in the RESONATE-2 trial in the gold curve. So you can see a very good disease control and long-term progression-free survival with ibrutinib-based therapy. It's consistent and similar with what we've seen with venetoclax-based therapy, but these patients require continuous treatment, and you don't get patients to an undetectable MRD status, which we think is important. I think is important for a number of reasons. In terms of risk factors and who we define as high risk, we used to think of 11q deleted patients as high risk. That's not the case with ibrutinib-based therapy. As you can see on the left in the gold curve, the patients who get ibrutinib who have an 11q deletion look like they do a bit better than patients who don't have an 11q in the purple curve who are treated with ibrutinib. Also, we used to think of unmutated immunoglobulin gene as a high-risk feature. On the right, you can see patients do equally well whether or not they have a mutated or unmutated IGHV gene with ibrutinib-based therapy. 17p, though, we do think of as a high risk, and this slide summarizes data from the NIH group that shows a 6-year progression-free survival for 17p deleted or mutated TP53 at 61%. And among those patients, it appears that immunoglobulin mutation status may help also identify even higher risk patients if they have an unmutated immunoglobulin gene. Those are the patients in red. So that requires ibrutinib-based therapy. Acalabrutinib-based therapy requires continuous treatment until progression. Venetoclax we can treat for a year. and they can have several years off treatment with a deep remission. We were interested many years ago on combining these agents because they work on different targets and they have non-overlapping toxicities. So we developed at MD Anderson a trial of ibrutinib-venetoclax. We've published that data. We see about a 75% undetectable MRD rate in the bone marrow with 2 years of combined therapy. At ASH, I presented a trial that's referred to as the Captivate trial. This was a phase 2 randomized trial for patients who achieved an undetectable MRD status at the end of 12 cycles of combined ibrutinib plus venetoclax. And the goal of this randomization was to determine whether or not patients did better with continued ibrutinib after that year if they were MRD negative or not. So they were randomized, as you can see highlighted in the red box, to a placebo or continued ibrutinib monotherapy. These patients were all MRD negative at the time of randomization. Those patients who are MRD positive were randomized to continued ibrutinib monotherapy or continued combined therapy, as you can see below in the box below that. And I'll show you the outcomes for each of those. This trial did enroll patients who had high-risk features, including 17p deletion mutated TP53. These are the MRD negative rates at the end of 12 cycles of combined therapy: 75% MRD negative in the blood, 72% in the bone marrow. This was a large multinational, international study, multi-center international study. So there were a number of different centers that were enrolling patients on this study, and it was nice for us to see confirmation of our response rate that we saw at MD Anderson in this large international study. This shows you that there were 86 patients who were confirmed undetectable MRD. 43 were randomized to placebo, 43 to ibrutinib. There were a few more patients with higher risk features among those who were assigned to ibrutinib therapy, as you can see highlighted in red. And then there were 63 patients who had persistent MRD and were randomized to either ibrutinib, 31 to ibrutinib monotherapy, and 32 to continued combined therapy. This is the primary endpoint. This is the outcomes, which is 1-year disease-free survival for the MRD negative patients. And you can see there's no difference in these curves in terms of 1-year disease-free survival if patients were randomized to ibrutinib, continued monotherapy versus placebo. And these data, for me, substantiate the concept of fixed duration treatment, achieving an undetectable MRD status, and an expectation for patients to have a longer-term progression-free survival without continued treatment. So that is the bottom line for me for this study. This shows you what happens to patients who were MRD positive and were assigned to continued combined therapy versus monotherapy. It's a little bit hard to see this. The hatched bars did not come through very well, but the bottom line here is that there are patients who do benefit from continued combined therapy. So for me, this raises the question of what is the optimal duration of treatment for patients who don't achieve an undetectable MRD status. Do we treat them for 2 years of combined therapy, etc.? And I do think there is value for continued treatment. This slide was just to remind me to tell you that we did not see any safety signals or unexpected toxicities with this combination, and patients tolerated it very well. Moving to the relapsed setting, the MURANO trial was updated at ASH. This was a 5-year update for the MURANO trial. This was for patients who were treated in the relapsed setting. They were randomized to venetoclax rituximab versus chemoimmunotherapy with bendamustine rituximab, all for previously treated patients. And this slide shows you on the left progression-free survival at 54 months median for venetoclax-based therapy in this setting. And overall survival is on the right, improved overall survival with venetoclax-based therapy in this trial and in this setting. Patients who achieve an undetectable MRD status at the end of treatment do better in terms of progression-free survival and overall survival than those patients who have persistent disease. Now, the MURANO trial gave 2 years of venetoclax compared to CLL14, where patients received 1 year of venetoclax. And on this trial, the CD20 antibody was rituximab instead of obinutuzumab as in the CLL14 study. This summarizes, for patients who achieve an undetectable MRD status, what the kinetics of relapse for MRD are in the middle. So the median time to MRD relapse was about 20 months for those patients who are undetectable. And from time from MRD relapse to progression is shown on the right, and that's a median of about 2 years. You can see sort of a plateau effect on the middle curve, which is time to MRD relapse. So there are patients probably who are remaining undetectable and have long-term MRD relapse-free survival and therefore progression-free survival, even among patients who are treated in the relapsed setting. Well, okay, that didn't come out. But this slide was intended to show, let's see, this is long-term data outcomes for patients who receive ibrutinib monotherapy in the relapsed setting. And show that the median progression-free survival with ibrutinib monotherapy is about 44 months, which is consistent with what I just showed you with venetoclax-based therapy on the MURANO trial. The high-risk patients, again, even in the relapse setting and in the frontline setting, remain to be those patients with 17p deletion, as you can see highlighted in the red curve. For this ibrutinib monotherapy RESONATE trial. And with ibrutinib-based therapy, there was a prognostic model that showed the factors that were associated with shorter progression-free and overall survival for ibrutinib-based therapy, and those 4 factors are highlighted here. And I think we should pay more attention to some of the others that we haven't been more recently, which is beta-2M and LDH when patients are going on ibrutinib-based therapy. And these are just the curves that support that prognostic model. Pete Hillman presented data on the ibrutinib-venetoclax combination in the relapsed setting. We did a trial also that included relapsed CLL. They're seeing and reporting about a 40% MRD negative rate for this combination in the relapsed setting. And those are also summarized here in this plot. And they also are working on the optimal duration of treatment because they've modified their trial to allow an extended period of treatment until patients are MRD negative. And they also presented at ASH these data that indicate that patients who achieve an earlier response do better and are more likely to achieve a deeper response with this combination. And the progression-free survival curve on the left and overall survival curve on the right for this combination. So we're seeing very good, very deep remissions with the combination, including in the relapsed setting. I think some of those patients are cured. We just need longer follow-up, and we need to monitor for MRD relapse to support that statement. I think the last couple slides, I just want to touch on a new drug that appears to be very active that works in patients who have failed an irreversible BTK inhibitor and have developed resistance. This is LOXO-305. This is a very selective reversible BTK inhibitor that was shown to have activity in vitro and in animal models in cells that have acquired the cysteine 481 mutation associated with resistance to the irreversible inhibitors. This phase 1/2 experience showed very good tolerability with this drug. The maximum tolerated dose was 200 milligrams daily. And among patients, you can't see the responses on the right for this slide, but the response rate improves with continued treatment, and we did report at ASH responses among those patients who are refractory to ibrutinib or an irreversible BTK inhibitor, as well as venetoclax-based therapy. So this drug, I do anticipate seeing it approved, and it appears to be a very active drug, including in patients who are refractory to the irreversible inhibitors. This is duration of response for LOXO 305 and progression-free survival on the right. So this is my summary slide that sort of reviews the concepts and thoughts that I went through when I gave my talk. For first-line therapy, we have very active, effective drugs. With BTK inhibitor-based therapy, we're talking about long-term disease control with continuous treatment. With BCL2-based therapy, and particularly with our combinations, we're talking about fixed duration, deep remissions, time off treatment. My opinion is, and my observation is, that we're transitioning into an era of combined targeted therapies with this objective. 17p deletion and mutated TP53 remain high-risk features. Those are patients that we definitely need to work on to improve outcomes. But I do think in the targeted therapy era, for patients over 65, my opinion is that with the targeted therapies, their expected lifespan is not shortened by their diagnosis of CLL. And we're working on strategies to cure them with the first definition that I reviewed in my first slide. So with that, I'll thank you for your attention and be happy to take any questions.
Thank you so much for being on time. And now we're going to have the questions. So starting with the first one, a 40-year-old CLL 17p deletion positive, no comorbidities. Which one you prefer to start with, Ibrutinib or venetoclax?
Yeah, so this is a young patient with a high-risk feature. This patient has a high-risk feature even with the targeted therapy. This patient should absolutely not receive any chemotherapy or chemoimmunotherapy. This patient should receive targeted therapy, either BCL2 inhibitor or BTK inhibitor. If we're talking about standard of care and not on a clinical trial, my preference is for a BTK inhibitor because as I mentioned, I don't like the concept of fixed duration treatment for 17p deletion. I like to put them on a treatment and maintain them on treatment, sort of protected with treatment, because I think in the near future, we will have effective treatments for these patients. We're still working on them, and so I want something to treat the patient and long-term manage the patient until we have something better for them. Perhaps it's going to be CAR T or some other agents, but we do know the BTK inhibitors work for this patient and the BCL2 inhibitor worked for this patient. For this patient at MD Anderson, my preference would be to put them on a clinical trial with combined targeted therapy, because I do think the combined targeted therapy may get them in a deep enough remission where they can get off treatment, but we just need more data to substantiate that statement.
Okay, thank you so much. The next question is for Dr. George. A 40-year-old male patient with CML started on frontline dasatinib, no other comorbidities. BCR-ABL at 6 months was 12% mutation analysis negative. And the question, do we prefer to switch to another TKI, and which one? The second thing is, or to continue on dasatinib till 12 months and assess the cytogenetic evaluation.
Well, this is an interesting patient because there is a borderline response, 12%. I am assuming that this is on the international scale, so I'm gonna take that as an assumption. I would definitely do a cytogenetic analysis at the 6 months as well to see what that represents. Because if this patient has at least a major cytogenetic response, then I will feel more comfortable even continuing therapy. In general, at that level, I tend to be more patient, and I know many of my colleagues in the CML field tend to recommend to jump therapy even at 3 months with more than 10%. But my experience has been that these patients can still continue to improve over time. So, first, again, do cytogenetic analysis, or at the very least FISH, but I would prefer a cytogenetic analysis. If I'm going to switch, I'm not going to switch to a second-generation TKI. They are the same. So there's very little chance that you're going to get anything better. you could get an improvement in the response, but it is possibly the same that you would have achieved with dasatinib. There was a randomized study of dasatinib versus nilotinib frontline from Japan at ASH, and it showed those curves are completely overlapping. So they're the same. So if I'm going to switch, I'm going to switch to ponatinib. But again, my first reaction would be check the cytogenetics at 6 months, continue the dasatinib, make sure that you're optimizing therapy, minimize interruptions, etc., and check again at the 12-month mark.
Okay, thank you. So what's the best timing to use combination with the start of therapy, or in case of deep response was not obtained down the road? I'm talking about the CML cases regarding the combination therapy.
I think combination therapy frontline is very difficult to justify. None of the studies have shown any real benefit. I think that the potential role of combination therapy is more likely to be later on. As you mentioned, those patients that have a good response but not the deep molecular response, potentially add an agent. What agent, we don't know. The studies, I showed something on ruxolitinib, and there's still ongoing studies, but our experience was not good. The combination of 2 TKIs with asciminib sounds very intriguing. I kind of like that, but there are 2 TKIs, kind of similar mechanism of action. Venetoclax is intriguing. There's different options, so we don't know which one to use. But I think if we're going to use combination therapy, it'll be more in that context, in the later responders but not deep molecular responders.
Okay, and how about the combination of PD-1 inhibitors and CML patients?
PD-1?
Yeah, nivolumab. There are like trials. Still, it's a phase 1 trial.
Yeah, there's been some attempts at that. The first trial was done only in blast phase and didn't show much, but that's a difficult test. I think that there is the potential. CML is a very immune-prone disease. It could be that you, especially using it, I would again use it only to deepen the molecular response later on. And I think it is possible that you need relatively low doses, few doses, so it wouldn't be as onerous on a patient. Because those patients are taking pills and they don't want to be taking intravenous medications. They don't want to get sick. You don't want to risk having, immune problems, etc. So I think there's the potential for benefit there, but we need to see the data. Of course, as you say, there are clinical trials ongoing. They'll have to be very, very convincing. Can they be? I think so. I think there is a potential, but we don't have data yet.
Right. Thank you so much. So then the other 2 questions to Dr. Philip. Were those excellent results with the newer combination obtained in the real life setting outside the clinical trials? What do you think?
Well, in fact, we have very, very few data on real life assessment of quadruplet combination, for example, with VTD-DARA or Wierda-daratumumab or carfilzomib, Lendex, KRD plus a CD38 antibody. No data are available. We have some data on VTD in the real life. Triplet combinations were published in the real life, showing almost similar results compared with those achieved in routine in clinical trials, but with quadruplet combination, not at all. And this is something that should be definitely evaluated in the future.
Right. The last questions. Where, like any of the trials, assess the quality of life, and in particular with the use of the multiple drugs for prolonged time and overlapping toxicity in multiple myeloma cases, especially those patients they are like a middle age or above 60.
Yes, in fact, for example, with the Cassiope study, we looked at VTD versus VTD daratumumab plus stem cell transplantation, and we looked at quality of life, and the data were published in the Lancet Hematology very recently, and we are showing that the quality of life is totally maintained. The addition of a CD38 antibody that is very safe, in fact, is not adding any significant toxicity. So I guess that this was also shown with other regimens. You know that, for example, with the DRD combination, Lendex versus Lendex plus daratumumab, in elderly patients at ASH, there was also some data on quality of life showing that the triplet combination, Lendex, daratumumab, is not associated with any toxicity or significant toxicity added on top of Lendex. And the quality of life was even improved, in fact, because you are controlling the disease much faster, in fact. So yes, we do have quality of life assessment. That's mandatory, I would say, for all recent phase 3 trials.
Dr. Amal, you are muted. Dr. Amal.
Oh, okay, sorry. The last question is, if we're going to mention or talk about the cost effectiveness and availability of those medication, have you thought about it? I mean, not all countries can get those medication, or some of the patients, they do not have insurance to cover the cost of that treatment. Any thought or idea how to overcome this?
Well, in fact, that's true that the cost now of new quadruplet combination with the addition of daratumumab, that is very expensive, lenalidomide, that is also quite expensive. We are reaching costs that are very, very, very high, in fact. And drug access and drug availability is really an issue. You know, even in the US, I know that my colleagues are now raising some concern about the cost of treatment. So definitely, we need to find other options. And one example, we are looking in the relapse setting at pomalidomide, dexamethasone, and daratumumab. And if you don't have access to dara, you can easily add on top of Pomdex cyclophosphamide. That is also very effective and probably act in synergy with an IMiD. And you can really have good progression-free survival data with Pom-Cyclodex as compared with other combinations that are much more expensive. So definitely, for example, in the recent paper published a few days ago, the International Myeloma Working Group recommendation for treatment at the time of the relapse, we are proposing alternative combinations, other combinations that are quite effective when we don't have access to carfilzomib, to pomalidomide, or to CD38 antibody. But definitely, that's a very important issue.
Right. There one more question: how to manage the resorbed bone after auto transplant, and when?
Sorry, I didn't hear the start of the question. Yeah.
Okay. How to manage a bone after transplant, and when?
Oh yeah.
After
Well, we have some guidelines of the use of bisphosphonate, for example, in the setting of autologous stem cell transplantation. These guidelines are published. We have the ASCO guidelines. We also have the European Myeloma Network guidelines. And usually, you know, in the setting of frontline stem cell transplantation, we are recommending, for example, bisphosphonates monthly for a period of time of 2 years, and not more than this, in fact. So this is one example of what we can do: monthly administration up to 2 years.
All right. Okay. So by that, we conclude our session. I would like to thank all our eminent speakers. We really enjoy it, and like by now we have almost 4,000 attending the session. So thank you so much, and hope to see you soon in other conference or visiting us in Saudi Arabia. Thank you all. And we are moving now to, we have a break and opening the exhibition.
Thank you.
Pleasure.
Thank you very much.
Thank you. Bye-bye. Take care.
Hi, Bill. How are you?
Bye.
Good. Jorge.